ठीक है,
हम चेक कर लेते हैं।
कर ले।
प्रियंका,
हाँ, गुड आफ्टरनून सर।
हाय प्रियंका,
हाय
आज
सर।
परसेप्टर कौन है तुम्हें?
सर डॉक्टर देवांग।
देवा किस हियर ना?
I told her sir, I think ma'am must be logging up.
हाँ, तो मैम को कांटेक्ट करो ना,
हाँ
because you
मैम,
have to start once.
सर मैंने बता दिया है मैम को।
ओके,
आगम मैम आ गए, लॉगिन कर लिया।
ठीक है, 3 बजे, we still have 5 minutes। बाकी तुम YouTube वगैरह भी चेक कर लो, चल रहा है कि
हाँ सर, वो चेक कर रहा है, आगम इज चेकिंग सर।
ठीक।
मैम इज ज्वाइंट। टाइम हो गया। ओके, कर लिया ना लोगों ने ज्वाइन। दिस इज द माइक, दिस वन इसी पे है, ठीक है। I'll start 2 minutes. Okay, okay.
Agam, if anyone is marking attendance?
Yes sir, Meet is marking attendance sir.
Agam, the same link will be followed for Dr. Nishan's class, na?
There's a different link.
Yes, sir. There will be a different YouTube link, but Meet same meeting will be used.
For Google Meet also,
For Google Meet, the same link will be used.
same link, na? Okay.
Yes.
ठीक है, I think Priyanka, you can start.
Okay, sir. Good afternoon, everyone. Today, the SR class, my SR class is on glaucoma drainage devices. My preceptor is Dr. Devang, ma'am. So, the principle of glaucoma drainage devices is to create an alternative pathway for the aqueous outflow into the subconjunctival or the subchoroidal space through a tube. So there is different evolution. They started with setons, then shunts, and then
I think
valves.
Devang, your mic is on, that's why there is a disturbance. All of you, please switch off your mic.
Okay. So setons, they are solid shafts that prevent wound apposition, facilitating the bulk flow by surface tension. And shunts, they are tubular structures that provide passive flow of fluid, and this passive flow can be either retrograde or anterograde. While the valves, there is a unidirectional flow of fluid. So a well-directed flow of fluids in case of valves. Now, this is the history of GDD. The first thing which was done in a very painful eye was that after puncturing the limbus, they put a horse hair in that place so that the wound apposition will not take place and the IOP will remain low. So Zorab, he in 1912 there was he used a translimbal silk threads, following which there were the Molteno implants, then the Bearwild, and then the most famous of it, the Ahmed glaucoma valves. They came in 1993. So the classification of the GDDs can be studied under the type of plate, type of material, and the type of opening. So the type of plates can be either rigid or the flexible. So GDD, they actually consist of a tube and a plate. So the plate can be rigid or the flexible, and the more the flexible the plate is, it will the more less the less it will rub on the sclera and less reaction it will cause, and hence it will be better for more of the for IOP management. Now the type of material, so basically what we want the material to be is that the fibroblast should not adhere to that plate material. So we create a bleb, and in between the plate and the capsule, the conjunctival and the capsule which has formed around the plate, there is a space where the aqueous can get accumulated, and from where it will diffuse slowly. So that is why we don't want the fibroblast to grow and stick onto the material of the plate. So it can be either silicone, just like the Bearwild, Cropin, and the Hamad, and polypropylene, Hamad and Molteno, and also hydroxyapatite has been tried. Now, on the basis of type of opening, GDDs can be classified into no resistance, GDDs with no resistance, and GDD with variable resistance. So, in no resistance, we have a non-valved devices, and the other we have the valve devices. Molteno, Bearwild, Chocut, and Adi, which is an Indian-made implant, are non-valved. While the valve, we have AGVs, Cropin slit valve. GDDs with variable resistance are the modified Molteno dual ridge devices and the Bearwild BioSeal, the latest of its Solex gold shunts. Now, what is the difference between valved and non-valved? Valved, they only drains fluid at a certain IOP, while the non-valved drainage rely on the resistance formed by the fibrous capsule or the bleb. The valves open valves open and the fluid is drained into the reservoir, where it is absorbed by the surrounding tissue. Bleb in the non-valved, the bleb grows around the implant and create a space for the fluid drainage and absorbed by the surrounding tissue. So the absorption and the drainage is same in both the valved and non-valved, while the only difference is the IOP drainage mechanism in valve and non-IOP dependent drainage in a non-valve device. So these are the types. Again, the Ahmed glaucoma valves can be either made up of silicone or polypropylene. The most commonly used is FP7, FP8, S2 and S3. So this FP7 and FP8, the plates, the tube are both made up of silicon. And in pediatrics, we are using this smaller version, that is FP8, while S2 and S3 simultaneously similarly have a polypropylene plate. So S3 is again a pediatric version of the S2. These are Bearwilt and the Molteno. Bearwilt is mostly silicon, and Molteno is polypropylene. So, Ahmed glaucoma valves. The valve mechanism that consists of a silicon elastomer membrane that separates with an IOP of 8 to 12. That means that this silicon elastomer membrane would separate only at an IOP of in between 8 to 12. If the IOP is less than 8, then the valve won't open and the fluid won't drain. So the pressure inside the intraocular pressure would remain around 8. While if the pressure is more than 12, then the valve will again close and it won't drain properly. So mechanics or the principle of AGB is, which we describe, the Venturi effect. What we can see here in this diagram is there is this Venturi chamber, which we called it's a quadrangular kind of a chamber, from where there is a surface. So what is the main principle here is that the flow rate is dependent upon is a multiplication of the area and the velocity. If the area is more, the velocity will be less, and if the area is less, the velocity will be more. So this maintains a steady flow rate into the big chamber. So that is what it is doing. It reduces the interstellar friction within the valve system, and the tapered trapezoid chamber creates a Venturi effect, and the fluid can drain from the with less resistance into the chamber. And the elastomer membrane regulates this drainage. Now the Molteno implant, it has a round polypropylene end plate. This is a modified version where there is a V ridge, and this V ridge is creates a kind of a resistance. So in the sudden post-operative period, there will be less chances of sudden post-operative hypotony. What happens is this V ridge, there is the conjunctival tissue that grows and try to presses this portion here. So there is a creation of two chamber kind of a thing, and hence there is a slow drainage of fluid from the tube into the plate, and hence less chances of post-operative hypotony. It can be either a single plate or can be a double plate. So if there is a single plate, so it can be inserted in between the two recti muscle. But if it is a double plate, so what we have to do is we have to use the two quadrants, and one has to be passed beneath the recti muscle and to be placed. So the most I'll be discussing the Sanjay. The most common site for the placement is supratemporal quadrant. The Bearwilt glaucoma implant, it is mainly consisting of it is made up of silicon, and this barium, it is barium impregnated. Why the barium impregnation is there? To allow it, this barium impregnation will be detected on any X-rays. If a person by chance come to us with a complaint of a ocular mass or something, if we are suspecting, if a person is operated and goes somewhere and he's suspecting a mass or something in the eye, so when we do a X-ray, this valve can show up and we can know that it is not a mass, it is actually the valve which has been placed. Also, there are other mechanisms to control the post-operative hypotony in the Bearwilt implants, which is these ripcord sutures or ligatures. What we do is, these are non-absorbable sutures which are tied at the end of the tube, and these can be opened later on, so that the aqueous flows slowly through the tube into the plate. This is the other implant, which is also known as Adi, that is Orolab aqueous drainage implant. It is an Indian made version of Bearwilt. It is cheaper and hence and more available to us. Molteno and Bearwilt, they are not available in India. So it is a very good replacement or a substitute for Bearwilt. The other thing which I missed, in the Bearwilt glaucoma implant, there are pores, or there are these you can see these pores on the plate. These pores are to allow the fibrous or the growth of the tissue inside it. So what happens because of the
I'm having trouble hearing you.
am I audible? So the mic just said that I cannot hear you.
You're audible.
Okay. So what happens through these pores, the fibrous tissue that grows, and the height of the valve is low. So the height, it when the height is low, there are also chances of there is low chances of diplopia, and also it keeps the plate in position. So I talked about the Orolab implant. They are also like Barwilt, and there are also pores in it, and the principle and the this thing is same as the Barwilt. So now we come to the indications where we use these implants. So multiple failed trabeculectomies are one of the major areas where we have to use these glaucoma drainage devices. Now the secondary glaucomas, we can give a trial of a trab, but we can give a trial of trab, but in case of a failed trab, such as in case of neovascular glaucoma, uveitic glaucoma, or a penetrating keratoplasty, any previous retinal surgery, patients with eye syndrome, patients with Sturge-Weber syndrome, they are the cases where these glaucoma drainage devices are indicated. They can also be used as a primary choice in these secondary glaucomas. Now again, the congenital glaucoma with failed trab, we can give a trial of glaucoma drainage devices. Scleral ectasia, cicatricial diseases, also we can consider these. Now, what are the contraindications? The contraindications are mainly to if there is a scarred conjunctiva, and also if there is a scleral thinning. Because what happened, we are inserting a foreign body in between the conjunctiva and the sclera. So there are chances, if the scleral thinning is present, this can this device can rub on the sclera and cause a scleral perforation. Also, if there is a scarring in the conjunctiva, wherever we are placing, in whichever quadrant we are placing the implant, the conjunctiva, the bleb won't function properly, because as we know that in trabeculectomies also, what is most important is a healthy conjunctiva for the fluid to drain. Here also, we are creating a bleb around this device, and in between the bleb and the plate, there is a aqueous is present, and that is absorbed into the lymphatics and the periconjunctival, the tenons, and the scleral vessels. So that is what is happening. So they are the two contraindications. The relative contraindication can be in case of a vitreous present in the AC, that can go and clog the tube itself, and hence it can fail the surgery. And the other thing is a silicone oil in situ, which is in situ, emulsified silicone oil can be present in the AC. So in that case, what modification we do is, we place the tube in infratemporal position, because the emulsified silicone oil is mostly present superiorly. So we place the tube in the infratemporal place in the AC. So AGV surgical procedure, I'm gonna just describe here. I didn't have a video, so I'm just doing presenting it in a short way. First of all, this AGV has to be primed. How do we prime this AGV valve? Is that we have the silicone membrane, elastomer membrane, which I talked earlier, is present here, and you have to apply a pressure of approximately 100 mm of Hg initially to open it up. Later on, after priming, this can open in between at 8 to 12 mm Hg, but initially you have to apply a 100 mm Hg pressure to open this. So in the OT, before implanting this, we have to inject a 2 ml saline into it, so that this is primed. Secondly, the quadrant we have to choose. So the most common quadrant, which I said earlier also, it's the supratemporal quadrant, because it is very easy to work there, and it is a little spacious, like it is very easy for us to work there. And also, there are less chances of diplopia in that quadrant. It is one of the biggest quadrant. So we place there. So what we do is, we do a a fornix-based operotomy is done. And first of all, we do with the help of blunt dissection, we go as posterior as possible into the posterior peritomy. Now what we do is first we place the plate in that, and this plate, the anterior margin of the plate has to be at least 8 to 10 mm away from the limbus. Then what we do is we have to trim the tube, and this trimming has to be done in such a way that the bevel end should be facing up, and also that the length of the tube from the limbus should be around 1 to 3 mm. Now what we do is, just like trab, we will make a partial thickness flap, and we won't do a deep sclerotomy. We won't make a deep sclerotomy. With the help of a 26 gauge needle from 1.5 to 1 mm away from the limbus, we are going to make a entry into the AC through the 26 gauge needle, and through that we are gonna insert this tube inside the AC anterior chamber. Now after securing the tube with the help of sutures, we will cover our partial thickness sclerotomy flap over the tube, and also we are gonna place a donor sclera or a pericardial tissue over the exposed portion of the tube, so that the tube doesn't rub off and does not show off from the over the conjunctiva, and there is no exposure of the tube. And later on, after fixing that, there are two eyes here on the plate, and we're gonna suture it with the non-absorbable sutures, and we're gonna seal the peritomy. So this is AJV. This is a one-stage procedure which are performing in the Ahmed glaucoma valve. While in Beveled and Molteno, since it is non-valve devices, so we have to do a two-step procedure. There, what we do is we first put the plate, just like we have done here, we put the plate and we allow it to stay there for 4 to 6 weeks, so that the capsule over it develops, and later on we insert the tube inside the AC, so that the post-operative hypotomy or sudden gush of aqueous fluid can be avoided. That is the two-step surgery. Now, any glaucoma drainage device, there are few steps in which the healing or the bleb formation is occurring. First of all, after insertion there is a collagen capsule formation, and then after that there is a surrounding granulomatous reaction which occurs. This reaction resolves in 4 months. Till when the granulomatous reaction is occurring, there is the capsule is very thick. Okay? And after that, the capsule matures, and it in 6 months, and it becomes thinner, and the filtration starts. So there are 3 phases which are described. The hypotensive stage, it lasts for 7 to 10 days. The IOP is low inside the eye. There is a diffuse edema, congestion, and the blood vessel in the tissue covering the episcleral plate of the implant, and the bleb is filtering. The device, the IOP is low. Hypertensive stage, as I said, when the capsule is thick and the capsule is developing, there is an elevated IOP which can reach up to 50 mm Hg in 4 to 5 weeks. And later on, when the edema subsided and the fibrous tissue or the capsule mature, it lands up into the stable phase, where the IOP stabilizes in between 8 to 10 or 12 mm of Hg. So these are the 3 phases. Now, one more thing I want to mention here: during the hypertensive stage, when the pressure is reaching 30 to 50 mm Hg, we don't just leave the patient like with a high IOP. We can start the patient, or we have to start the patient on one or two anti-glaucoma agent. They can be aqueous suppressants also. So we start the patient on the anti-glaucoma agents. Also, there is a role of fibrogenic drugs such as mitomycin C. Now, the intraoperative complication for glaucoma drainage devices can occur during the tube insertion and malposition. There can be a hyphema which can occur. There can be hyphema. They are more commonly associated in case of a neovascular glaucoma, where these devices are largely used, because this tube can go and rub the scleral, the iris new vessels, and can cause hyphema or hyphema. Also, there are, while since the tube is blindly inserted through the 26 gauge needle entry which we have made, so the risk of hyphema is again there. Scleral perforation can occur while applying the suture, while inserting the this thing tube also, and the suprachoroidal, there are chances of suprachoroidal hemorrhage as because of the sudden hypotony, and vitreous prolapse can occur. Now, the post-operative complication of glaucoma drainage device can be divided into early and late phases. Hypotony-related complications can occur, aqueous misdirection can occur, and suprachoroid hemorrhage. While the late, there can be erosion of the tube or the plate, tube migration can occur, diplopia can occur, and corneal decompensation can also occur. The most dreaded of it is the endophthalmitis, which can occur. In case of a tube migration, or in case of tube migration, there are extenders or expanders available, and you can replace the tube, or you can put those expanders. They are actually, what happens is, they are small tubes with a bigger diameter than the tube of the glaucoma drainage devices. So you can put on that, and then you can expand it. Now, erosion of the tube or the plate, this can occur, and then again you have to either cover it with another, you have to start antibiotic, and you have to cover this tube or the plate with these sclera, donor sclera, or pericardial tissues, etc. Corneal decompensation can occur because of the endothelial tube touching the cornea, and start from the beginning, it causes a localized endothelial loss, and hence it starts with a localized corneal edema. But later on, if this contact is maintained, so this corneal edema can expand to the center, and hence deteriorate the vision of the patient as well. Other thing, diplopia, which is because of the mechanical, or because of the plate which we have placed in the subtenance in the supratemporal quadrant. So diplopia is another problem which is accompanying the use of glaucoma drainage devices. Now, the outcomes, the long-term studies have revealed a success rate of around 65% in controlling the IOP. The Molteno implant in general lowers the IOP more than the Ahmed glaucoma implant, but have a higher risk of complications and need for resurgery. As I explained, these Molteno implants, we are doing a two-step surgeries. Just to avoid the sudden lowering of the IOP, or sudden decrease in the IOP, and thus the complications. The success is lower in pediatric glaucomas, and because these in pediatric age, the wound healing process and is different as compared to the adult, and their wound, they heal more, and the fibrosis or the reaction is also more, the healing mechanism. These are particularly successful in case of a secondary glaucoma cases, which now these are the suggested reading. You can look at these articles. I took my most of this thing from these articles, and Shield textbook and American Acad. So thank you. That would be it.
Okay, thank you, Priyanka, for the precise and presentation. So, the topic of this, we had glaucoma drainage devices in mind. So, the take-home message at the end, I think, is important, that this topic comes as a short note, and it is also asked in Viva. So, what you have to remember from this class is to take home what is the principle, is the classification, which Priyanka has very well explained, and what are the indications and contraindications for these implants. Rest of the surgical procedures, I think when you guys come to the glaucoma unit, this we routinely do in our OT, and it can be seen in the OT setup.
Just to add what Devang said, this could be given as a surgical video also. In MD exam, there is a Viva on surgical video only. They can play any of this video, AGV, and they can ask you any of the step or any of the complication, whatever Priyanka just discussed. So it can come in a surgical Viva also. Any questions? Devang, you can ask few questions to the residents. We still have few minutes left.
So I would like to ask, can any one of you just tell me the classification? Because this is what it is asked, and nobody, you can't enumerate the name of the devices in the exam. You just name one. Whose exam going back? Any volunteer? Mm, Diksha? Diksha? Are you there?
Yes, ma'am. Yes, ma'am.
So can you just enumerate how it was classified?
Ma'am, these can be classified based on document devices with resistance or without resistance. With resistance, without resistance, either valve or non-valve. Valve one is our Ahmed glaucoma, a non-valve are Molteno and Braidband. Hello, ma'am, am I audible?
Thank you, everyone.
I think let's move on to the next class. But there is some audio glitch, I guess, with Devang.
Sir, am I audible?
Yes, Sanket.
Good afternoon, everyone. Today I'm going to discuss the topic of steroids in uveitis, and my preceptor is Dr. Vinod Agarwal. So this is the basic structure of any steroid compound. It has a 21 carbon cyclic rings with 3 hexane and 1 pentane. So the molecules which attach here change the bioavailability as well as the different compounds. They differ only on the side chains. So first we'll discuss about the mechanism of action of steroids. So as we all know that corticosteroids are potent anti-inflammatory as well as immunosuppressive agents. So they inhibit the phospholipase A2, therefore inhibit both the COX and the LOX pathway and inhibit the production of prostaglandins and the leukotrienes. So they also inhibit several cytokine and adhesion signaling pathways associated with inflammation and vascular permeability. They also stabilize the blood-retinal barrier and enhance the tight junction integrity, making them good agents for reducing the macular edema. And corticosteroid receptors identified in iris, ciliary body, and the adjacent corneoscleral tissue. So this is a flowchart. So basically steroid compounds enter into the target cell by a passive entry and they bind to a cytoplasmic receptor protein. Now the steroid and the cytoplasmic receptor protein migrate to the nucleus and they cross the nuclear membrane where they bind to the DNA and causes changes in the mRNA transcription, which affects the protein production as well as the cell function. So the steroids act at both local and systemic level. On the systemic level, the effect is predominantly seen over the neutrophils and the lymphocytes. So this is a table showing the anti-inflammatory and the immunosuppressive effect of steroids on the neutrophil, mononuclear phagocytes as well as the lymphocytes. So basically the aim of our treatment in uveitis is to relieve the symptoms of pain, photophobia, to minimize the sequelae, prevention of any irreversible vision loss, prevention of recurrence, the limit the side effect of the drug therapies and reduce the inflammation and prevent damage to ocular structure. So before we move on to the steroid, so first we have to rule out any infectious etiology for the causation of the uveitis. If infection is the cause of uveitis, never start steroid at the first go. And second thing is, first standardize your degree of inflammation and the location of the inflammation. Is it anterior, is it intermediate, or is it posterior? And also document vision and IOP at the first sitting of the patient. And also ideally you have to wait for 3 months to say that the treatment which you have given is ineffective. And every treating physician should first set up a therapeutic success protocol for himself. Like the patient should have an increase in visual acuity, there should be a decrease in vitreous haze, there should be a decrease in the cells, there should be a decrease in photophobia and pain. So if these criteria are not met, then you can call the treatment as ineffective. And also mention if one eye is affected or both the eye is affected, because the treatment will vary. And also make sure the patient's general health, also take into consideration the general health of the patient, because in certain conditions like diabetes mellitus, the systemic steroids are a relative contraindication. So with this background, we'll move ahead. And in any case of uveitis, we will follow a step ladder approach. So first mainstay of uveitis is steroids. It can be either topical, regional or systemic, followed by NSAIDs, and then cryopexy of the peripheral retina in the pars planitis area, then immunosuppressive chemotherapy, and lastly pars plana vitrectomy with intraocular steroid injection. There is no hard and fast rule like we have to go in this order, but if we feel that we have to start 2 therapies at the same time, we can also include steroid as well as immunosuppressive together. So what are the various steroid agents we use? It can be classified on the biological half-life as short-acting, intermediate-acting and long-acting. What we commonly use are the intermediate-acting, that is prednisolone, IV methylprednisolone and triamcinolone acetonide, whereas the long-acting ones are the dexamethasone and the betamethasone. So the various routes of corticosteroid delivery are local delivery, which can be either topical, which can be either periocular, or it can be intravitreal. And the other one is the systemic steroids. It can be oral or intravenous. So the various topical steroid preparations which we commonly use are dexamethasone. It is either in a suspension form or a solution form. It is the most potent drug, and it has increased ocular side effects. The next is prednisolone. This is the most commonly used in our setup. It is available as acetate suspension or a phosphate solution. If you use a suspension form, you should advise the patient to shake the bottle before use so that the effective corticosteroid goes into the eye. So the acetate form, it has a biphasic solubility, therefore it causes a better penetration through the cornea. As we know that cornea has a stroma which is hydrophilic, whereas the epithelium and the endothelium are lipophilic. Hence you need a biphasic soluble drug in order to penetrate the cornea. Whereas the phosphate form, it is only a water soluble, therefore the penetration is not as effective as acetate suspension. So the degree of penetration depends more upon the concentration and the dosage frequency. And the other one is the fluorometholone. It is a weak anti-inflammatory agent, hence it causes less ocular damage. So this is a table showing the different topical preparations. What we commonly use is the prednisolone, acetate or phosphate, and fluorometholone. Now the topical steroids are effective in the management of only anterior uveitis and have little effect against the more posterior or the intermediate uveitis. However, in cases of Behçet's disease, vaginous polyarteritis nodosa, VKH, and sympathetic ophthalmia, we would like to use immunosuppressives as the first agents and not steroids. And the topical steroids are contraindicated in any acute herpetic dendritic or a suspected fungal keratitis where it may cause reactivation of the disease. So in cases of moderate to severe anterior uveitis, how would we go about? So we initially for the first 3 days we would like to give an hourly drops followed by 2 hourly for the next 3 days, and then slowly taper it based on the clinical response of 6 hours for 1 week, followed by 8 hourly for 1 week, followed by 12 hourly for 1 week, and then once a day for 1 week, and then stop. And coming to the regional steroid preparations, these are the various regional steroids. What we commonly use is triamcinolone acetonide. It is given as 40 mg per ml suspension or depot form. These are the systemic steroid preparations. What we commonly use is the prednisolone 1 mg per kg tablet, which is available as Visalone, and also IV methyl prednisolone. It is used as a 40 to 1000 milligram powder for IV infusion for 3 days. So I'll be discussing about periocular route now. Periocular injection can be either subtenon, that is posterior subtenon, also PST, or subconjunctival, transeptal, or retrobulbar. These are effective in a unilateral, intermediate, or posterior uveitis. The effectiveness of periocular injection is critically dependent on the proper technique which you use and also where you place the drug. The advantage is it provides rapid delivery of high concentration of the drug at the site of inflammation. So what are the indications? It can be used in intermediate uveitis, it can be used in posterior uveitis, pseudophakic cystoid macular edema, and also in acute flare-up of patients who are already on immunosuppressants. And also to avoid the side effects of systemic immunosuppression in your worst eye in an asymmetric disease as a depot if a patient is non-compliant to topical medications. And in the COVID era, if systemic immunosuppression is to be avoided, we can still use periocular route. So this is triamcinolone acetonide 40 mg per ml solution. It is insoluble in water, therefore it is good for a depot injection. It can be either preservative or preservative free form are available. It is moderate potency. So the dose which we usually use is 20 milligram 0.5 ml, which is preferred for PST, or in severe cases you can either use 40 mg per 1 ml, but there is high chances of increased IOP. So the pharmacokinetics of subtenon versus the intravitreal route. The subtenon injection may require 6 weekly injections, and its action generally takes 2 weeks to start, and it can last up to 3 months. Whereas the intravitreal route, it has a half-life of 18 days, and the measurable concentration of triamcinolone may last for 3 months in a non-vitrectomized eye. So there are 3 techniques of giving a PST. The standard one is the Smith and the Nozick method, where you use a 26 gauge needle in the superiotemporal quadrant. I'll be showing a video of this. The second is a cannula method, which was described at RPC by Professor Pradeep Venkatesh, where we use a polytetrafluoroethylene cannula in order to inject the posterior subtenon. So this is the image showing how to inject the posterior subtenon in the superiotemporal quadrant by asking the patient to look inferonasally. This is the video. So we ask the patient to look inferonasally, and after putting the paracaine drop, so we started some around 5 mm from the limbus in the superiotemporal quadrant, and then with a side to side movement so that we don't penetrate the globe, we enter almost till we reach the hub of the needle in a gentle side to side fashion, and then slowly inject till we notice a bleb formation here. So this is the standard Smith and Nozick method. And the cannula method, which I was talking about, it uses the 26 gauge, it uses a cannula of an IV needle, and first you have to insert the trocar for 2 mm, and then you retract the trocar, and then you insert Hello? So after we retract the trocar, we inject the cannula in a posterior manner. As this is flexible, it will mount to the conformation of the globe, and can go as posterior as possible where we inject it. So there are less chances of perforation. And this is the orbital floor approach, where you can either go it via transconjunctival or also transseptal as we give the periocular block. So the comparison of techniques, the advantage of Smith and Nozick method was what it was a quick method. With the right technique there are minimum complications. However, since it's a 26 gauge needle, the risk of perforation of globe may be higher. The cannula method has the advantage that the risk of globe perforation is low, whereas the problem is that the bending of the tip of the cannula and greater patient discomfort as it is going more posteriorly. Whereas the orbital floor injection, the risk of globe perforation is very low, though it is slow acting. So the efficacy of all the three are almost equal in terms of improving the visual acuity. However, there are few chances of raise in IOP, the more is seen in cannula method. So contraindications of PST is a known case of glaucoma if the patient is a steroid responder, if there is a suspicion of infectious uveitis, if there is necrotizing scleritis or an acute conjunctivitis. Coming to intravitreal steroids. So triamcinolone acetonide is the preferred drug for intravitreal injection, and it is used to manage non-infectious intermediate and posterior uveitis and is associated complications like cystoid macular edema. It is administered as 4 mg per 0.1 ml and the effect lasts for 6 to 8 weeks. So you need to give repeated injection if the response is not adequate. In order to overcome this problem, there were implants which were devised, which are sustained release implants. So Ozurdex, it's a dexamethasone 700 microgram. It's a biodegradable implant. It degrades into poly-DL-lactate co-glycolide followed by water and CO2. Thus it disintegrates in the vitreous cavity. It is injected via 22 gauge preloaded injector. The effect lasts for 3 to 6 months and it is FDA approved for chronic non-infectious uveitis. Then the Retisert, it's a fluocinolone acetonide implant which is 590 microgram. It is a non-biodegradable and it's inserted in the vitreous via 4 mm sclerotomy and is sutured to the sclera. The effect lasts for 3 years and the complications are about 90% cases will have cataract and 40% will have glaucoma. The recently FDA approved in 2018 is fluocinolone acetonide 180 microgram implant. It is also non-biodegradable implant which is injected via 25 gauge preloaded injector. The effect lasts for up to 3 years and it is also an FDA approved for chronic non-infectious uveitis. So this is the Ozurdex implant and this is the Retisert. And there was a trial conducted which was a multicentric uveitis steroid treatment trial. It was used to compare the effectiveness of the standard therapy, which is the systemic corticosteroid therapy, versus fluocinolone acetonide implant for the treatment of non-infectious intermediate posterior panuveitis. So they found that systemic therapy, that is steroid, and when needed added immunomodulatory therapy, improve the visual outcomes, control the inflammation and reduce macular edema similar to the intravenous fluocinolone acetonide implant. So they said that systemic therapy as well as the intravitreous implant both are almost equally efficacious. Hence they concluded that oral steroids or immunosuppressive can be administered safely for at least 7 years. Now systemic steroids, these are indicated if the patient is having a bilateral disease which is sight threatening, or if the patient is a case of severe unilateral disease who have failed to the topical or the periocular therapy, or if they are intolerant to periocular injections. So how do we start steroids? As said by Gordon, it's called Gordon's early dictum. They have said that you have to use enough soon enough. In case you are using it slowly in a less quantity, the disease progresses to an extent where it cannot be reversible. So you use enough soon enough. And you initiate with 1 mg per kg prednisolone daily and slowly taper it. And you should not taper abruptly as there is risk of precipitating Addisonian crisis and also recurrence of the disease. Next, IV pulse we rarely use, but it can be used in cases of severe bilateral sight-threatening posterior uveitis. And commonly we use methylprednisolone 1 gram per day for 3 days, which can be repeated once a month. So how to taper systemic steroids? So in case you are using more than 40 milligram per day, you reduce it by 10 milligram per day for the next 1 to 2 weeks. If the dose is 20 to 40 milligram per day, you reduce it by 5 milligram per day every 1 to 2 weeks. If the dose which you are using is 10 to 20 milligram per day, you reduce it by 2.5 mg per day for the next 1 to 2 weeks. And if the dose is less than 10 milligram per day, you have to reduce it by 1 to 2.5 for every 1 to 4 weeks. Do not lower below 10 milligram per day if the disease is not quiescent for about 3 months. And if you are suspecting that the disease treatment will take more than 3 months on steroid, then you have to consider adding a second agent like immunomodulator. So the contraindications of systemic steroids are all infectious causes like fungal, syphilis, toxoplasma, herpes, candidiasis, and tuberculosis. The relative contraindications are peptic ulcer disease, poorly controlled diabetes, osteoporosis, and pregnancy. So these are some of the ocular side effects of the steroids, which are glaucoma. Mainly it's a secondary open angle glaucoma, cataract, posterior subcapsular, susceptibility to infection, impaired wound healing. The side effect of periocular administration is fat atrophy, extraocular muscle fibrosis, globe penetration, and CRAO. Whereas topical can lead to punctate keratopathy and paralysis of accommodation, and systemic it may lead to central serous chorioretinopathy. These are the various systemic side effects of the steroids: endocrine, GI, musculoskeletal, cardiovascular, psychosis. And since these have osteoporosis can be caused by these conditions, so these drugs, so you have to consider giving vitamin D and calcium tablets, and in case of menopausal women, hormone replacement should also be considered. So to conclude my talk, I would like to tell you that treatment of uveitis you have to individualize for each and every patient. If it's a uniocular disease or a binocular disease, if it's a uniocular disease limited to the anterior segment, you have to give topical steroids as a first line. If it's intermediate or posterior uveitis, it will not be effective with just topical steroids. So first you should give a trial of posterior subtenon or periocular route. In case it's not enough, then you might give a trial of intravitreal steroids. In cases of bilateral disease with posterior extension, sight threatening, always start with systemic steroids. And also at each follow-up, you have to make sure that you document the intraocular pressure, because glaucoma is a very common complications with the use of steroids. And you have to standardize the evaluation. Suppose one physician is documenting the cells as 2+ in the first sitting, and some other person will document it as 1+ or no cells. That will change the treatment for the patient. So you have to standardize according to the Sun classification, and always rule out infection before you start steroids. Thank you.
Thank you, Sanket. There is a question for you from Diksha.
Among FML and loteprednol, we commonly use FML as it is more potent than loteprednol.
So Sanket, I have one question, because I have seen a lot of residents whenever they give steroid in entry uveitis, they add a prophylactic antibiotic.
Prophylactic
Hello?
antibiotic.
Praful,
Yes, ma'am, yes.
is that question answered, Praful, amongst FML
Yes,
and
ma'am, FML.
Lotepred? Huh?
Yeah,
No,
FML.
I think no. I think the thing is, and I Praful, you could correct me. FML is more for ocular surface, and Lotepred is more, or prednisolone is more for the aqueous. FML is more for ocular surface inflammation, and I don't know how it is being used in our uveitis thing, but FML is more promoted, or fluorometholone is more for ocular surface, and prednisolone is more for the aqueous inflammation, for the anterior chamber inflammation.
Sanket, Dr. Vinod is there.
Sir, unfortunately, sir could not attend because sir is posted in COVID duty, sir.
Okay. So what is retina point of view? Because we just want to know that, because this is what cornea people we believe, that FML is more useful for surface. That's why we usually prefer FML. But loteprednol may be effective for intersegment penetration and more effective in uveitis. But you just said the reverse of
So
that.
the topical which we use Mainly, so we use prednisolone acetate or this thing, or the second option is fluorometholone. Very rarely we use lotipred.
Okay, so why is there any specific study to justify that
No,
statement, or it is
so
by
no, sir.
convention that you don't
Mainly,
use it?
so it's by the use. People have mostly used prednisolone acetate and prednisolone phosphate suspension.
No, no, if you compare fluorometholone versus loteprednol, both are low potency steroids.
Both are
Okay,
low potency.
so
Yes.
are there any study that compare the efficacy of both of these drugs in uveitis?
No, sir. No.
Okay, in cornea also there is also no specific study to compare the efficacy of both this, but people have noted that okay, FML is good for surface activity. That's why that is preferred. But I think you should go back and if you find any definitive material on this, then you should put it in that group.
Yes,
Okay,
sir.
or you should give that to, or in maybe next class, just 5 minutes before the start, you can just give us a short comment about that.
Oh, sure, sir.
Okay, my question was that I have seen a lot of people when they see a case of acute uveitis, they give steroid, but simultaneously they give antibiotic cover also. So is it required,
No,
or
it's
if
not
it's a case
required,
of
sir.
antibiotic, just give steroid and
So
cyclophosphamide and
just,
that's it?
so we have to rule out just the systemic, like if the patient had history of dendritic, herpetic dendritic ulcer or any ulcer corneal issue. If not, then there is no need of any prophylactic antibiotic therapy.
Okay, you can start with steroid and
Yes,
cyclophosphamide.
yes,
That's
sir.
it.
Yes.
Okay, and is there any question from residents? And how do you titrate the frequency of steroid?
So it's
Depending on what? Because
based on the
if it's a case
clinical
of
response.
uveitis, whether to give 2 hourly, 1 hourly, or 4 times a day. Are there any guideline for that?
So it's based on, it's individualized, sir, based on the clinical response, and if you're giving, if cells are 4 plus 3 plus, then you preferably start 1 hourly or 2 hourly steroids, and if the cells are like 1 plus 2 plus, then you would like to give 6 times a day or so. So based on the clinical activity and also the clinical response, you taper it.
Okay. There are few questions for you. I think if you can
Can
see
Ozodex
the
be
chart section.
repeated? Yes, Ozodex can be repeated. How often? Again, it's a individualized call, but the Ozodex effects last for up to 6 months. So if with one injection of Ozodex the effect is seen, you might not repeat it. But if not, after giving an Ozodex injection, later on you can again start them on steroids, topical or oral. And if still the response is refractory, then you might consider giving another Ozodex injection. Is there any
Is there
indication?
any indication for excision of PST?
Yes, if the depot administration, if there is a severe rise in intraocular pressure, and so you might want to take out the injection depot which you have injected.
Any intractable glaucoma that is
Yes,
not
sir.
being controlled, you have
Intractable
to take it
glaucoma
out.
after giving PST, then you might want to take it out.
Okay, then I think we are done here. Now I would like to request all the resident, please attend the next class. Vijit, you can call all the resident, those who are not there. This is a class. This is specifically arranged. This is specifically Professor Atul has asked us to keep it for you people because the number of cases of COVID are rapidly increasing in New Delhi. So it's all about all the precautions that you have to take. What in RP center as well as in your hostel